I want to thank everybody for joining us this morning for VLU Empower All webinar series. I'm joined here today by my co-moderator, Lina Vargas, and my amazing friends and speakers who will talk to us about their thoughts and experience with stents and everything here and there involved. So I'm going to turn it over now to Lina Vargas, who's my co-moderator on VLU. And before I do that, I just want to say thank you to VLU Executive Board and also to Lowell Kabnick, who's been an incredible mentor to me. Lina, take it away.
Thank you. All right, well, this is a jam-packed schedule, so we're going to dive right into our first presenter is Dr. David Dexter. He's board-certified vascular surgeon at Centara Vascular Specialists in Hampton Roads, Virginia. And he is going to talk to us about the evaluation, workup, and treatment of patients with May Thurner.
Perfect. Can you guys all see my screen? Are we ready?
Yes.
Well, Kathleen, thank you so much for the invitation to do this today. Let's get started. So it's always hard when you don't know your entire audience. So some of this will be a little simplistic, some will be a little bit too deep, and we'll try to hope to aim for the middle. May Thurner syndrome, also known as Cockett syndrome, is compression of the left common iliac vein by the right common iliac artery and the vertebral body at lumbar 5. And you can sort of see that on the pictograph here, sort of in both dimensions, in 3D, as well as sort of through an axial segment. It accounts for 2 to 5% of all DVTs seen. It seems to affect young women for the most part, and that may be due to the way the lordosis is different in the spine. It presents as a provoked DVT postoperatively in the peripartum or postpartum period, and also with oral contraception in a fairly common number of people. May Thurner syndrome is a combination of the anatomic findings of the compression that I just told you about, as well as symptoms of venous congestion. And I think the biggest disclosure of this talk today is that if you're going to engage in treating a compressive syndrome and putting in a stent, because there's a series of amazing talks after mine about taking things out, taking out stents, taking out coils. It's understanding that a syndrome is a combination of an anatomic finding and a series of physiologic symptoms. And anatomic findings alone, in the absence of those symptoms, is not a good indication to treat. So the clinical presentation of May Thurner syndrome is typically unilateral left lower extremity pain and swelling, often without a provoking factor. It can be also an acute onset for a DVT, or it can just be chronic dwelling swelling for years and years. If someone has pre-existing venous disease, it can potentiate their symptoms. So for a patient who has unexplained hemosiderin deposition in their mid-calf, lipodermatosclerosis, or a venous ulcer, suspecting a central component is really important. So in the absence of a prior DVT, isolated left leg symptoms consistent with superficial venous insufficiency really should have some sort of a workup, particularly with unprovoked left-sided DVT, and even more particularly if they've had a thrombophilia workup that's negative. So when we talk about diagnostic workup, superficial venous insufficiency duplex ultrasound is sort of the initial test that many of us do when we identify a patient with isolated leg problems that we think to be venous. And some people will extend that study up to the vena cava, but the majority of studies stop infrainguinal. So identifying patterns of waveforms, specifically at the common femoral vein, because that's the most sensitive area to look, but also can be present in the femoral vein and the profunda vein, can demonstrate suspicion for a more central problem. On the right, you can see normal phasicity of the common femoral vein at rest in A. You can see an early loss of phasicity at B, and then a truly monophasic, non-phasic waveform in the common femoral vein in C. And that's probably the single most common thing for me to find in my clinical practice that's then going to tilt me towards doing either an IVC duplex, if your lab can handle that, and if not, a perioperative CT venogram or an MRI venogram to identify an underlying iliac vein compression. Ultimately, the gold standard in my practice is venography with on-table intravascular ultrasound. Once I've identified the right patient for treatment, this is where we talk about what we're going to accomplish. So all patients get conservative therapy to begin with. That's compression and elevation, and good skin care is a must to prevent disease progression. There's a talk on whether we should or shouldn't offer prophylactic anticoagulation for these patients. And the short answer is, for everyday life, my answer is no. So my first case, you'll see, was actually referred on anticoagulation, despite the fact they'd never had a thrombotic event. And to this day, that's the only patient I've ever had on anticoagulation prior to treatment. That being said, if someone has severe compression and symptoms, and we decide on a non-operative approach, I will prophylax those people a little more aggressively in a perioperative window. If they have prolonged travel or prolonged immobility, those people will get recommended low-dose anticoagulation for the clot-prone events they're about to undergo. The next thing we'll talk about, this will be part of the talk in a few minutes, is angioplasty and stenting. And this can be done both for non-thrombotic iliac vein lesions or thrombotic iliac vein lesions that have underlying May Thurner compression. The primary patency rate for treating non-thrombotic lesions is excellent. At a year, it's in the mid 80s to mid 90%. And the primary assisted and secondary patency rate of stenting really does approach 100%. What's interesting is the clinical improvement in stenting people. Clinical improvement in stenting well-selected patients shows a 3-point VCSS reduction in 12 months of about 65% of patients, which means that you're only improving 2/3 of people by about 3 VCSS points in things we're willing to publish, which does say that without really good selection guidelines, we might just be stenting lesions and not syndromes. So part 2 of my talk is really, what do I stent, how do I stent it, and what are the challenges? I sort of ask myself 3 questions every time I go in to stent a venous lesion, the majority of which will be for either compression or for an underlying fibrosis or stenosis. So I want to differentiate these patients between thrombotic, post-thrombotic, or non-thrombotic. Do I consider these lesions to be acute or chronic, and do I consider them to be simple or complex? The next part of this is sort of, where do I do these? So as a surgeon, I have access to hybrid ORs, I have cardiac ORs, and I have cath labs and angio labs. I can do this myself with local anesthesia and my own sedation, or can partner with anesthesia and do this with general anesthesia and an intubated patient. And then I need to figure out, how am I going to access this patient? So for the vast majority of non-thrombotic May Thurner positions, I consider them to be simple. I consider their disease path to be chronic, and I consider them to not need a complex intervention. So the majority of these cases are angio cases or cath lab cases. I do these with local and my own physician sedation. And the majority of these people, I put prone on the table, assuming they can tolerate prone positioning. I do popliteal access so I can see their inflow and ultimately treat them centrally. I think from an intraoperative imaging standpoint, you can't just stent your compressive lesion. When we look at failures in all of the stenting trials that we have, the majority of failures are because we've stented a lesion and we haven't considered what else there is going on in that limb. You have to make sure that if you're treating a patient with compressive disorder, with a May Thurner that has an inflow stenosis that's post-thrombotic or from something else, that you have enough flow into your stent to maintain its patency. You want to make sure you get past your lesion. So you need to stent up to the IVC and potentially just into it. And you want to try to not cover the contralateral iliac vein. And we'll talk about that in a minute. Depending on how much stent length you want to place, I do not like stenting below the inguinal ligament. It is done routinely. It's important to stent peripherally into healthy vein, but I reserve crossing the inguinal ligament for cases where it appears to be mandatory. What is mandatory to me is not crossing the profunda vein peripherally, because you want to ensure that you use the profunda as your robust flow. So when I start with my venography, because the venous system is low flow, because the patient's volume status, and we'll hear about that from some of our speakers later this morning, Because our volume status may be different, you may need to augment your flow. You can do that a couple of ways. Sometimes I'll squeeze the calf muscle after I inject contrast. That's a bit more physiologic. I'll sometimes have the patient pump their calf while I'm working. Sometimes I'll put a 20 cc syringe onto my sheath and inject saline behind my contrast. Or sometimes I'll just use larger volume injections, and that works really well too. I always get multiple oblique views. There is no vessel outline like angiography, so you have to know what you're looking at when you're doing it. And every central venous case for me has an intravascular ultrasound. It allows me to measure the diameter of vessels above and below, and then identify the chronicity of my thrombus. The next part of this is stent sizing. I'll show you that in a few minutes on a couple cases, but you want to size the stent for the iliac you're treating. You can do that three ways. You can size immediately cephalad or caudad to the lesion you're treating. You can use the contralateral side and look at that for what the anatomic norm is for your patient, or you can sort of just guess and say, what is the anatomic norm for a patient of this size and of this gender? So what does this mean? It means the average male patient at 200 pounds needs a 16 millimeter common iliac vein stent, and the average woman probably needs a 14 millimeter stent. Reserving larger diameter stents for patients who truly need them, because oversizing can become a problem. And again, we'll hear about that from other speakers later. You want to ensure you've oversized your stent by just enough that it doesn't migrate, but not by too much that you have chronic pain. That's 1 to 2 millimeters over the size of the vessel. And again, stent length should be limited from healthy vein to healthy vein. When we talk about stent overlap, overlapping stents should be done at around 2 centimeters. Too little overlap can cause what's called a hinge, and those stents can disconnect and cause a stenotic point in between those two. And too much stent overlap can potentially have too much synthetic into a patient. You also want to be very careful not to have stent overlap at the deepest point in your pelvis where the hypogastric vein is, because both those stents may not follow the pelvic curve. And you really don't want to have stent overlap under the inguinal ligament because there's so many dynamic forces there. You should consider putting your smaller stent in first and then funneling it up to the larger stent, but that's probably the most stylistic thing I'll say about stent sizing today. And then lastly, for how I do these cases, anticoagulation is really personal. There have been some trials on this, but these are sort of my thoughts. All venous stents get dual antiplatelet therapy. If the patient's being done for a compression with underlying post-thrombotic syndrome or an acute DVT, I will add therapeutic anticoagulation to their DAPT. If it's truly a non-thrombotic May Thurner lesion, I let them go home on DAPT alone. At 12 months of that treatment, if they're on dual therapy, I either stop their second antiplatelet agent or I convert their anticoagulation to prophylaxis. And at 2 years, I do the opposite maneuver. For a May Thurner non-thrombotic lesion, I typically keep them on dual therapy for as long as they'll let me. Most of these patients are going to auto-regulate off their P2Y12 at a year or 2 years, and that seems to be okay. So that's sort of the academic part of my talk. Stenting knowledge is really hard. We've learned a lot over the last 10 to 12 years. I don't know where I am on this, but I do feel that I sort of hit the bottom part of my learning curve a couple years ago, and I feel like I learn a lot from meetings like this and hearing from other experts. I'll show you a case, and I'll show you some of the things that I've learned the hard way. This is a 22-year-old woman who very clearly came into me with a heavy, painful left leg. She's never had a DVT. She was seen by a cosmetic vein specialist in my community. She worked for Verizon. She couldn't do her job anymore because she couldn't stand due to pain. She was in 30 to 40 millimeter thigh-high stockings, and her IVC duplex showed almost no flow out of her leg with an obliterated left common iliac vein. Again, she was started on prophylactic anticoagulation, which surprised me, but I wasn't going to say no to that, and then referred to me for venography. This, I think, is the most pathognomonic venography I can show you. We used to say that you have to have collaterals in your central venogram to believe you have May Thurner, and this patient clearly has it. They have an iliolumbar vein on the left, and they're crossing from left to right hypo, filling their right common iliac vein. This is the pathognomonic picture in the textbooks. Um, you don't necessarily have to have this if you have clear compression as well as severe symptoms. But I think seeing a picture like this really does tell me I believe my patient's going to get better when I treat her. So in two views, both AP and lateral, we've identified where we want to be. I've used intravascular ultrasound to find peripheral to my lesion, how big this is. And I was able to put a stent, in my mind, too far in. And you can sort of make out where the right common iliac vein is on her. But the crossing point of the iliac artery really isn't always over the left common iliac vein alone. In her case, it sat squarely across the bifurcation. I did put this stent right where I wanted to. That right there really does tell me where the underlying iliac artery is going to the right. And you can see that my stent does impact that right on, but I'm also all the way up into the vena cava. This is what her IVUS looked like at the point that I had to stent her, and I see absolutely no iliac vein on this. And on the left-hand side, you can see the contralateral iliac artery as it crosses over this point. And this is what she looked like when I was done. The aspect ratio, and you can see the minimum and maximum diameter in the bottom right, is almost 1-to-1, showing how round we were able to make her vein. This was a purpose-designed venous stent. So just for a few seconds, since I think I have about a minute left, I was going to show you how I don't stent, because hearing how great all of us in this audience and this panel are at stenting, I think is really helpful. But as I've aged, I feel that showing my flaws or showing the things that I've missed or almost missed can be really, really helpful. So landing a stent short has some consequences. This is a stent that's too short. This is a common iliac vein stent inside another common iliac vein stent. Despite the fact that purpose-driven venous stents want to form curves, ultimately they will go straight in a straight segment of vein. And that arrow represents the deepest point of the pelvis where the hypogastric vein comes out. And you can see how straight and stiff my common iliac vein is. And that angle is going to become a problem for this patient. So do not do this. This was actually done because this stent up here is not a purpose-driven venous stent. This was an arterial stent. So this patient actually had a stent placed 15 years ago, and they completely compressed this 15 millimeter, 16 millimeter, very, very short stent, and then they got restented. Stenting 2 cephalad also carries consequences. This is a wall stent that was placed across the iliac bifurcation up into the vena cava. This patient did great for about 10 years, and then they thrombosed, but they didn't thrombose their stent. They thrombosed the contralateral side. And for compressive lesions, this is more common than thrombosing the index stent. The 10-year patency rate of a left iliac vein stent for non-thrombotic reasons is about 3%. But if you cross the cava, the 10-year thrombotic rate of the contralateral iliac vein is probably close to 10%. So don't do this. Some of these lesions just hide in plain sight. If you don't see this, there's actually a man laying on the couch in camouflage. This is not just a couch. So this is a patient where we had to cross them centrally. They had occluded their contralateral side, and you can see that they now got their stent extended down to the left pelvis. The problem is that's not the left external iliac vein. And I don't know if you can see that on screen right, because when my partner put these stents in, he was convinced that his sheath was in the left common femoral vein. You can see the femoral head. You can see that his sheath makes a very weird curve on an AP shot. So you can see what's happened here on a magged up view. While he did terminate in the common femoral vein, he did it through the obturator foramen. And he's completely mangled this stent after 4 or 5 years. I know that Audra's going to give a really great talk on how to take these stents out. I actually did take this stent out following the Mayo Clinic paper that I think she contributed in years ago. And it was a nightmare getting this thing out, or at least getting the femoral portion of this out. And it did improve his persistent nerve pain. So a lot of pitfalls on things to avoid. But overall, thank you guys for the opportunity to talk about compressive iliac vein lesions and at least how I think about these.
David, thank you so much for sharing your knowledge. I always learn so much from you. And I think that what I'd like to do is go ahead and introduce Dr. Duncan, because she is on call and she has an emergency coming up. So we got to let her get to work. But
I mean, I'm okay if my partner appeared, so he's covering me. So if you want to answer questions, that's okay too. I'm fine. I have the time.
Okay. Well, I think why don't
Or
we
I
go
can
ahead?
go.
Yeah, why don't we go
Okay.
ahead and let you go? It is again my distinct honor, pleasure to have you join us on this webinar this morning. And you're a superstar in venous disease, as well as the other panelists. But go ahead and tell us and educate
Okay.
us.
Great. I'm going to open my, hopefully, can you guys see that?
Yes.
Okay. So I mean, I have certainly trained and done a lot of venous work. I don't consider myself a venous expert anywhere near the other panelists. But I would say that because of my, experience in sort of quaternary referral centers, that I do get sent people with kind of unusual things and things that they want taken out that no one else will, and so on. So I'm going to talk a little bit about open surgery for stent removal and a bit about coil removal, although I think that will get discussed a little later in the session. There's no, I love giving talks that literally have no data. There's some case reports. I actually don't even have, fortunately, that much data on it, other than some, quite old cases. But I tried to find as much as I could in terms of telling this story. So I have no conflicts. So, we need to know why we would ever need to remove a stent or a coil. And in going through a review, I'd say probably one of the most common is pain. So people have a stent in, often for May Thurner, and maybe it's abutting the IVC wall and going into a space where there is some nerves. So people do talk about pain. Often that's associated with oversizing of the stent. Obviously, stent migration, if it goes somewhere it shouldn't be, particularly the heart, that it would need to be removed. Thrombosis is not really a true indication. It's kind of a secondary indication, because most of the time, like you can see in these images, they can be recanalized with the techniques we have now. And I would say as we get better in sizing and better, venous stents and actually venous dedicated stents, many of these things are indications for stent removal are going away. What probably won't go away is nickel allergy, and I know we're going to talk about that again. And then in terms of coil removal, I do actually remove a fair number of coils during my nutcracker procedures in patients who've been coiled for pelvic congestion, just in the due course of the surgery. So we'll go through some of these. So how do we work that up? I mean, obviously, I mostly use CT venogram. Ultrasound can be used. If the stent has migrated, you might need an X-ray or an echocardiogram to see kind of where it's gone. This is an image from Desai's paper in Endovascular Today, where there was this compressed and thrombosed stent that was into the IVC, and they ended up they felt it was oversized. They went and surgically removed it and replaced it with a PTFE graft. But that's it's a nice image. Typically, this is how I would work them up. So there are ways to retrieve stents endovascularly. I'm not going to so much discuss that, and it's extremely rare, and it has to be at a time frame where it's still not incorporated into the stent wall, but people have reviewed that. But if you do need to remove them open, really you need to know what the indication is. If it's thrombosed and the patient's asymptomatic and you're removing it for, say, a nickel allergy, you could maybe just remove it alone and resect it and ligate it. That's rare, though. Typically, you need to either remove it and leave the vein patent, or remove it and reconstruct. So those are the decisions you need to make before surgery. So I think a couple caveats if you're talking about any kind of stent, honestly, arterial or venous, even though we've never actually gone in the abdomen or the pelvis or wherever you're going. Once there's a stent in there, there's a fair amount of inflammation. They do generate, some or perivenous or periarterial inflammation. So I do consider it redo surgery. If I do have to reconstruct, I use PTFE. I wouldn't usually use vein for venous patients because they probably need every vein they have in the leg. So I would just typically use the PTFE. I'm not really addressing anything with infection because the stents that we put in that are not covered stents rarely get infected. So although in theory, there's been some case reports on it. If there's a ton of pelvic inflammation associated with the stents, you got to watch out for the ureter and maybe stent it beforehand. And obviously, if it's migrated, that's going to depend on the location of the stent of how you process that. This is a case report of an unfortunate stent that a few years later after placement was found up in the heart. It's hard to see in the chest x-ray, but there is a stent sitting there in the right atrium. But you can see it, it's kind of lodged in that tricuspid. You can see it on their echo. And then this is a picture I really never want to have to see, which is just the stent sitting there through the tricuspid valve. So that required, cardiopulmonary bypass and removal of the stent. And that was, written up in this case report. They did a nice job in removing that safely. So this, I think, is the paper that Dr. Dexter is referring to, which was written by Animesh Rathore, was one of our fellows when I was at Mayo, where they used other people do this. They just did a very nice write-up of it. A 36-year-old woman who had severe back pain after her stent was there for several years. Again, it was felt that it was potentially oversized. And so I'll just walk through what Dr. Glavitsky did to remove this. So there's the stent, and you can see kind of it poking out through the right lateral wall of the IVC. It's not truly out, it's just really pushing it. And that was the main concern for their pain. She had a really full workup regarding other sources of pain, and they really couldn't identify anything else. So I think that's an important point, is that you don't want to immediately blame it on the stent. You want to make sure that it's not, because you certainly don't want to go through all the effort of stent removal and then they still have the pain. So that was the first workup. And then when they decided they were going to remove this, this is just, I'll just walk you through it. But so basically you can see in the panel A, that's the stent is kind of in that wall of the vein, and the right common iliac artery is crossing it. And basically what they did was they made these little poke holes. You could see the stent wires, and they used what we use for varicose vein avulsions, that little crochet hook, and plucked them out and then pulled them out. And you can see in the Sharps box, there were, basically all of these wires removed. So the stent was kind of broken up into its components and then removed from the wall. But unfortunately, at the end, they did an ultrasound and they found this big flap into the IVC that they didn't want to leave. So they opened it up and found this sort of pseudo-intima that was lining it, and then excised that to make a smoother endoluminal surface. And then that's sort of the final picture where you can see basically they tacked down the pseudo-intima near the edge of where they left it, and then they closed the IVC in the left iliac vein primarily, and that was a good result for her. This is the final picture of the left. You can see it's wide open, and actually it was not really compressing at that point, so it didn't feel like they needed anything further for potential May Thurner. So everything was left be. So I'm just going to talk a little bit about coil removal. And again, this is my own case here. So I see a lot of patients that don't see me first. They go to through GYN or so on with potential pelvic congestion syndrome and get coiled primarily. And then that gives them sort of a raging nutcracker syndrome because they have no more decompression of the left kidney. So this patient had a very high grade compression of her left renal vein, but had all these coils in. She was convinced that her pain was due to the coils alone. So I did tell her that when we did her left renal vein transposition, that I would take out all the coils that I could. So I took out what I felt like was like, this is the bowl of coils. I took out probably, I don't know how many yards of coils. I just kept pulling and pulling and pulling, and eventually they're stuck. And so I didn't want to create bleeding, and I didn't want to tear the vein that the coils were in. So I kind of stopped, and I had thought I'd taken out, I thought for sure the final images would look like, almost everything was out. And then in her post-op CT, you can see how many were still left. So I was pretty it's amazing how long the coils are. So I think, you can do your best, but I think it's very difficult to take them all out, especially when they're in these long, skinny veins, if you don't want to kind of go into the pelvis and ligate everything. So I'll conclude here. Basically, you rarely have to remove iliac stents, but if you do, that you have to keep in mind that they may be complicated by persistent inflammation. So, there's a variety of techniques. You can excise them and reconstruct them. You can excise them and preserve them, like in the case report from Dr. Glowitsky. And coil removal may be incomplete if well incorporated, but I know we'll hear about that a little bit more shortly. So I'll end here, and then obviously we can do questions however you guys want to do them. So.
Kathleen, do you want to, for the sake of time, and Audra, do you think, how are you doing on time? Do you want to stay on?
I can stay. I'm covered now, so I can stay. I found my partner. He appeared.
So what do you think? That case that you presented with all those coils that were left inside, I mean, that was very impressive. How did the patient do long term, even leaving those behind?
Yeah, she was fine. I mean, I think it was psychologically that she felt like they were the coils causing it, when really it was the left renal vein compression and the venous hypertension. So clinically, she's great. She just was really hoping that she'd be coil free. I don't know, there's psychologically that there was a need for her to have them out because she felt like that was causing her pain. But now she knows now. I mean, she's not illogical. She understands now that it's fine to leave them in there. And I didn't think they were causing her pain. And I mean, she wasn't behaving like an allergy or anything like that. And so she's fine.
Yeah, I think that's one of the most difficult issues with these kinds of patients, because a lot of times it's hard to tell what's what, including the emotional or the psychologic pain. Because these people, when they come, usually they've been desperate for years, have had no answers, have done all of this Google research, right. And they come with such high hopes, that these procedures, whether it's coils, whether it's stents, it's going to make whatever symptoms go away. And great if they do, but then it's a terrible situation if they don't. And this is kind of like the reverse, where she may have been thinking that it was the coils, and
yeah, no, absolutely. So. And I mean, I clearly told her that if all she wanted me to do was take coils out, that wouldn't be the procedure I would do for her. So she was understanding, but it does take, I mean, I see a lot of compressive syndromes in the body, and I slot like extra time for all of them because a lot of people don't understand them. They've been told a lot of things along the way. They read a lot of stuff on Google. And so it takes a lot of time to untangle that information.
I agree with that. Absolutely agree with that. Kathleen, do you have any other questions for Audra before we move on? I know we have some questions from earlier for David, but we'll come back to those if that's okay.
Sounds great.
Okay, so just for the sake of time, let's keep moving. So next we have Dr. Khanjan Nagarsheth. He's a vascular surgeon and professor at the University of Maryland Medical Center in Baltimore. And he will review his paper on bypass for patients with nickel allergies next. So Please take it away.
Hi, can you all hear me?
Yes, we can, and
Okay,
we can see your
okay.
slides perfectly.
Okay, cool.
Thank you
Sorry.
for joining us.
Of course. Thank you for the invitation. I really appreciate it. I'm at the airport right now, so I apologize for the background noise. But so I'm KJ. I'm one of the vascular surgeons here at the University of Maryland, and we'll talk a little bit about our experience with patients with nickel allergy. I won't belabor what's already been said. Dr. Dexter did a great job discussing the anatomy and the background of what iliac vein compression and the symptoms that we can see with that, and some of the modern treatments for it, and showed a lot of really great pictures. So nickel allergy, so it's a very interesting thing, and as Dr. Duncan mentioned, there's a lot of these compressive patients out there that are more and more being tested for metal allergies and are being found to have metal allergies. So, we as a society of vascular specialists need to understand how to address this increasing prevalence in something that we never really saw 10, 15, 20 years ago. So the overall incidence of nickel allergy in the general population is almost 10%. Depending on who you read, it can be even higher. Women account for the majority of cases, and the incidence in women is estimated to be between 14 and 20%. One of the things that I find so interesting is that the sensitization of nickel allergies comes from piercings. This is part of the reason why it's more prevalent in women. So with the number of piercings increasing in the population, this increases the risk of developing a nickel allergy. So the more piercings someone has and the more exposure they've had over the course of their life, the more likely they are to develop a nickel allergy. I think this is a very interesting thing, especially since nickel is so ubiquitous in our world. It's hard to get through our world without having exposure to nickel. Stainless steel contains nickel. Anyone who has a cell phone contains some exposure to nickel, right? The microphone in a cell phone has nickel in it. That's one of the metals that's used to make it. So these are some of the things that I use to flush out whether someone actually has a nickel allergy. But nickel allergy is a type 4 hypersensitivity reaction. It's where Th1 cells secrete cytokines and activate macrophages and cytotoxic T cells that can cause macrophage accumulation at a particular site. The most common forms are contact dermatitis, a tuberculin type reaction, and can lead to autoimmune diseases. Primary nickel dermatitis is eczematous reactions in the area of the skin that's in contact with a nickel. Secondary nickel dermatitis is more widespread throughout the body. It can occur from anywhere, can occur from ingestion of nickel-containing materials, even transfusion, inhalation of these materials, and implantation of medical devices, right? So there are reports out there of people getting this secondary nickel dermatitis from things like using a star close and getting a reaction from that, needing that explanted, stuff like that. So some of the things that we see, multifocal facial edema, hives, urticaria, that can happen immediately following implantation, but it is also a delayed type reaction. So one of the ways that I test for these patients that have a patch test that's positive is I usually send them home with a venous stent, and I tape it to their forearm, and I have them come back in 4 days. I tell them, don't take this off, shower with the plastic bag over your arm, but come back in 4 days and let's take a look and see what happens. Because what I found is sometimes they will develop a local dermatitis from that stent just being on their skin. It's not perfect, but it seems to give me a better sense of who's going to tolerate what. And sometimes the symptoms are reproduced when you place a nickel-containing stent or any kind of material on the skin. This is a very interesting graph, right? This chart shows you the nickel content in the majority of stents that are available on the market, the most common stents, not all of them, but the most common, right? So even covered stents, right, because they have stainless steel, have nickel within them. Now you have to be careful, right? Because sometimes covered stents have exposed bare metal parts to it at the edges. The Venovo stent has 55% nickel containing within it. The Vichy stent, no longer on the market in the United States, 55%. The Zilver-Vena, 55%. The Medtronic Abre, 55%. So the venous stents, the more common venous stents available, have a very high amount of nickel. Interestingly enough, the wall stent, the venous wall stent, which was initially a tracheobronchial stent, now it's a venous stent, has the lowest amount of nickel out of the traditional venous stents, 14 to 16%. So maybe there's something to that the wall stent might be a better stent for these patients with a documented nickel allergy. So the workup and management, right? We're evaluating cutaneous hypersensitivity reactions. I work very closely with my immunology colleagues and my allergy colleagues at the University of Maryland. We get an eosinophil count, we do lymphocyte stimulation tests, and then they evaluate for cytokine productions in these patients. This is a very nice algorithm that was put forward by Shalak in 2012, which we kind of use too to determine whether someone needs something removed. If they have a positive metal test, then you look at whether or not they have symptoms. Do they have symptoms or not? If they do, and they've had a device implanted, is it really necessary to remove? Yes or no. If it is necessary to remove, is it safe? You know, as Dr. Duncan said, sometimes these are kind of arduous things, and I tell all these patients that, you know, putting the stent in was easy. Taking it out is going to leave them in a much more difficult and precarious situation, which makes our surgery a little more challenging. So you look and see if it's reasonable and safe to remove. If it is reasonable, consider removing it, and you probably have to replace that vein. That when I remove these stents from either the renal vein or the iliac vein or anywhere these stents are placed, oftentimes I have to replace it with something. And here's just a couple different cases, and I'll talk about some of the things that we do. So left common iliac vein stenosis, we've seen these pictures. You know, you got compression by the right common iliac artery, you got the ascending lumbar vein collateral, you got cross pelvic filling, IVUS showing kind of significant compression. So anteriorization is something that I've done and that we do a decent amount of, where we kind of dissect out the common iliac artery on the right side circumferentially. We free it up off the vein. We free up the entire left common iliac vein all the way down to the confluence with the hypogastric vein to the vena cava confluence. There are multiple small veins that we ligate with Prolene suture. Some of the larger veins that have developed, I try not to divide them. I ligate them with a bioabsorbable stitch like a Vicryl or something like that, but I don't ligate them. I mean, I don't divide them, because in case this repair sometimes fails or anything like that, you want that to be able to recanalize and give the patient another option, because for the most part, a lot of these patients are quite young, have a lot of life left to live. When you bring the vein anteriorly, it has a lack of length, right? Because you're bringing it over the arch of the artery, so you have lost a little bit of length. So you always have to give a little more length to the vein. I find that it's best to use an interposition conduit. So I will often tubularize a piece of bovine pericardium. Sometimes we'll use PTFE. Sometimes we'll use vein, depending on what we find. You know, if they have a very incompetent GSV or something like that, I'll harvest the GSV and I'll panel it out, and we'll use that as our interposition conduit. I find you don't really need more than 2 to 3 centimeters of length for this interposition. And that's performed end to end between both sides of the transected vein, and restores flow. And we always do a venogram before and after to see our completion. This is a bypass technique that we do if that's not common. That's oftentimes if there's webbing or synechia within the vein, if the vein's not a good quality. As Dr. Duncan mentioned earlier, I'll use PTFE. It works really well, especially for our onco resections, for when we have to remove pieces of the vena cava or iliac veins for sarcomas. This works great for this purpose as well. I'll use anything from a 10 to a 14 millimeter PTFE graft. It's usually done, I'll do it end to side on the common iliac vein and end to side on the IVC. And I try to keep this as short as possible. What I found is when I keep them super short, about 3 to 4 centimeters in length, it doesn't require any kind of adjuncts, doesn't need an AV fistula created anywhere else to keep it open or anything like that. So these are kind of my single surgeon retrospective review. 47 patients treated with symptomatic iliac vein, left common iliac vein anteriorization or bypass between July 2022 and October 25. A lot of them had stent explants at the time of this. All patients had documented nickel allergy and were considered by their allergist or immunologist to have severe symptoms, and did have severe symptoms of their non-thrombotic iliac vein lesion. collected their baseline demographics, age, history, and outcomes. So the average age, 21.9 years, plus or minus 7 years, 95% female, most presented with leg swelling and pain, many with back pain, more than half with abdominal pain. We checked Civic 20 scores before and after. Before was 80.9, 68% had hypermobility, and 66% had POTS. Estimated blood loss for the procedure, about 55 plus or minus 26 cc's. Operative time, hour and a half or a little bit more. Length of stay, 3.5 days. We've gotten that down in more recent months. Follow-up, about 12 months plus or minus 6 months for this population. Our post-operative Civic score went down from 80.9 to 27.5. And symptom relief, when we look at these patients, 68% had 100% symptom relief. Greater than 75% symptom relief occurred in 85%, and greater than 50% relief occurred in 95% of this population. So this is the results that I talked about. It was statistically significant for the decrease in the Civic 20 score. Complications after these surgeries, 19% had urinary retention. As you can imagine, in this area, the nerves going to the bladder are also in this area and have to be moved out of the way, just like when we do an aorta bifemoral bypass. Ileus in 4%, stenosis occurring in about 15%. And in the anteriorization group early on, we had occlusions in 6%. Bypass, we've not had occlusions in the bypass group. We did have a 17% reintervention rate, where we've had 6 patients with angioplasty and 4 that ended up needing bypass after anteriorization for failed angioplasty. These are the post-operative duplices that we see. You see the vein going on top of the artery here instead of underneath it like it was before. Just some more representative pictures of the surgery. These are our duplex flows. You can see as it's traveling over, pretty decent waveforms. This is a renal vein that I had to explant a stent and replace with a tubularized bovine. So this is what I use for the tubularized bovine, where I take a bovine patch, I wrap it around a 36 or a 40 French chest tube, and I do a double layer closure on one side and use that as my inner position. This is a patient who had a severe nickel allergy, had a common femoral vein occlusion. We did an endovenectomy of the common femoral vein, but the vein was basically left with nothing behind, so I had to use a tubularized bovine conduit here to replace the common femoral vein. These are some pictures of these stents that I've seen in the renal vein. This is I like using the laparoscopic camera when I do these surgeries, just because it gives me good sterile pictures on the field. But this is a venous stent that was placed in the renal vein. As you can see, it's sort of migrated and there's a big size mismatch. This was resected and I replaced it with a bovine interposition conduit there. This is a wall stent in the common iliac vein. As you can see here, it was protruding through the wall of the vena cava. This is the multiple strands of the wall stent that were removed when I did this. And, just like Dr. Duncan mentioned, it's a nice little nerve hook that I use to remove each strand individually and then repair the vein with a ton of proline. This is a video that one of my fellows took at the time of removing. So you can see here, we're grabbing the individual strand of the wall stent and grasping it. And it just comes out as a really long kind of metal piece here, a strand. And it works. That technique works really well. Dr. Glavitsky published that before. This is an explanted, I believe, a Venovo stent, also for a nickel allergy. Vein had to be reconstructed after that with PTFE. So in conclusion, known metal allergy does not always correlate with clinically significant allergy, especially given that nickel desensitization can occur. This makes it difficult to determine what amount of exposure will elicit symptoms, even in patients with documented nickel allergy, but it is something we need to be cognizant of and be thoughtful of and mindful of with these patients. Stent explantation is feasible in symptomatic patients, and May Thurner is an anatomic condition known for that causes venous outflow obstruction. I think it's underreported. I think we all do. Anteriorization or bypass is safe and effective for these patients if you need to use it. And it can be considered in patients that have some sort of contraindication of stenting. So with that, thank you very much.
Amazing talk. With full transparency, the reason why I really wanted all these experts on this webinar this morning was because I have such a patient that actually Dr. Nagarsheth was kind enough to see also. So I would like to, because of the sake of time, I would like for Professor Davies to tell me how to take a coil out of a patient. So, and then we'll hopefully have enough a chance and time for questions. So, Professor Davies, please take it over. You're muted.
Realize that.
Thank you. We can't hear you.
Can you hear me now, Kathleen?
Yes,
Sorry,
yes.
I was
Perfect.
just trying to go back to my original slide. I'll start here. This is basically a review that many of you will know about the pelvic vein congestion syndrome that was done by Mark Meisner and Kathy Gibson. And what was interesting in this review now that was published 11 years ago, there really was very little evidence or any suggestion about the problems with nickel allergy or with respect to coils potentially having to be removed. But overall, you can see that some of the results may not be perceived as being that great. And we've also done a review again in our review. When we reviewed the literature, there wasn't a lot with respect to people having to remove coils. But again, there were some issues with respect to complications and particularly with respect to embolization. Now, we've talked about embolization. There's already been some discussion. I'm going to keep this fairly short and talk about nickel hypersensitivity and the removal of coils. This is the Peter Glavitsky paper. But basically, very much, if there is a high suspicion of allergy, then the only good option may actually only be to remove the coils. And just really to emphasize what some of our previous speakers have done, it is often forgotten, and some people forget to ask patients, do they have any nickel allergy or problem with pierced earrings or various things? And there is an importance, if somebody does suggest it, what you do about diagnostic patch testing. And there will obviously be some people who've never been exposed to nickel, and they are then exposed to a medical device with nickel, and they develop a nickel problem. And I'll talk a little bit more about systemic disease in a minute. Now, I'm only going to give you two cases. This was a 44-year-old lady who only had, and we'll show you her picture, venous flares and occasional leg pain. She was seen at an institution and had a duplex venogram. Decision was that she should be coiled. She categorically states that nobody asked her about a nickel allergy, which she knew that she had. And she went on to develop some symptoms. And these are the plethora of symptoms that you can develop. But just to illustrate to you that this lady not only had skin symptomatology, GI symptomatology, some neurological and general itching. Now, what is often difficult to ascertain in some of these patients is because they have been treated for abdominal pain, that it can actually be sometimes difficult to differentiate them. But this is what the lady actually presented with. And I dealt with this lady. You can see where her coils were on the right and left-hand side. So the important thing was before proceeding to surgery, and unfortunately, I haven't got lots of pretty pictures like some of my colleagues had because I'm not particularly good at taking them at the time, is that this patient was appropriately worked up and counseled that actually we may help her with respect to her symptoms, with respect to her nickel allergy, but it may not give her any guarantees. So she had a midline laparotomy, and the bowels were obviously moved medially from both sides, and the coils were removed, and basically you end up removing the whole segment of the ovarian vein. And I will talk to you a little bit about another case, which isn't one of the cases that I'm presenting today, but sometimes the whole of the left ovarian vein actually completely disappears, and you just more or less see these coils just sitting in the retroperitoneal space, and one or two have actually sort of migrated, certainly in my experience, more laterally. But this lady did have symptomatic relief. The second case, and I did actually have quite a lot of letters and things, but to show you, but it took quite a long time to do some redaction. But this is the summary of the case, and I will go into it in a little bit more detail. This lady had previously had her pelvic coils done once. She then returned, had some further symptomatology, and they were replaced. She then came to me because she was having a problem with her coils, and we'll talk a little bit more about that. And I only managed to remove most of the coils because once I was into the pelvis and trying to get them out of the internal iliac vein, I'm afraid I decided that in this particular case, the best thing was to actually abandon trying to do it. But you'll see why that is probably of interest, and I'll go into a bit more detail because now she wants the rest of her coils removing. So these were some of the pictures, and here you can see the plain abdofilm on the right-hand side is where the coils have been left in the internal iliac vein. So this lady, as you can imagine, is quite a problem. She's a 34-year-old. She's had 6 vaginal deliveries. So I asked for a second opinion from one of my colleagues just to see if they thought I was doing the right thing. So this is just to summarize, because it's very nice when you send somebody for a second opinion. They do this beautifully nice long summary with respect to various recommendations. So if we look at this lady in 2018, she'd had left-sided abdominal pain at another institution. She'd had her left ovarian veins embolized. Initially, there was improvement. At 2 to 3 weeks, the symptoms became worse. She then underwent a further embolization, and this was done in 2022. She also then subsequently went on to develop quite marked nausea, rashes, sensitivity. I saw this lady, and I was then going to talking about removing her coils. I did ask for a second opinion from Steve Black, who many of you will know if Steve had any other thoughts, because Steve and I tend to send quite a few patients back and forth to each other, because quite a lot of these patients do have psychological issues as well as many other things. So in 2023, as I described, I removed all of the coils other than the left internal iliac vein. She had significant improvement in her abdominal and pelvic symptomatology. So she then developed some generic symptomatology that would fit with an allergy. We did initially send her to an allergy specialist who said she did have a problem with respect to nickel, and she was then told about all the potential risks of death going potentially into the pelvis. And then I asked for, as I said, for another second opinion. She went back to Steve again, and Steve said, look, this would be quite challenging and not recommended. But we're now got this patient with a confirmed allergy and who states quite categorically they're well aware of the risks. So keen at the risks, she says, look, I accept whatever risk you're going to give me. You've heard a summary of the second opinion that I had from a lady who you'll all know, Sarah Anita. I'd be very intrigued as to what all your thoughts were and what you would do. So we very recently discussed this now 39-year-old lady in our multidisciplinary meeting, which has about 10 vascular surgeons and 6 interventional radiologists. And there was quite a bit of skepticism about going back in to try and remove these internal iliac vein coils. So where we are at the moment is that she's going to have another opinion from another allergy consultant, and we are going to perform a PET CT to see if there is any further inflammation in that area, and then make a decision as to whether to go back in to remove those coils. So in summary, if you're confronted with somebody whose coils you are thinking about going to remove, I think you no patient should now go and have coils without somebody at least asking them a question as to whether they have a nickel allergy. It's a bit of the same if you're going to use venous seal glue. you really ought to ask people if they have got any acrylic problems. But these patients, when you are going to take them for their coil removal, you have to be absolutely clear with them that their symptoms may not be improved. And you may need to remove these for pain, and I do not understand all of the pathophysiology of why these patients get a chronic pain syndrome who have got coils in. There are undoubtedly those people who obviously have a systemic nickel allergy syndrome, and that, in a way, is probably an easier ask, but they all need careful evaluation before you think about taking their coils out. Now, there are some people who have, I've very much an open surgeon, and I've done these cases of my series open, but there are people who have removed some simple ovarian coils, particularly on the left-hand side, laparoscopically. And that's all I've got to say. And I think this is a very interesting area. And thank you very much for asking me that, to share some experiences. And I'm happy to answer any questions.
Appreciate all of you. What an incredible lineup here, and incredible experience. And as I mentioned before, I do this really, the nice thing about getting to pick a topic is that I have such a patient, and it is very distressing and difficult. One thing I do want to add, in this particular patient that I had, she does have a nickel allergy, and I used a coil that is a platinum coil and that has absolutely no nickel. And I made sure of that. So really the reason to remove it is more because she has pain associated with the new coil that was placed, even though all her pelvic symptoms improved. So anyway, that's what led me to you all, to find out what it is that I need to do. I do want to get back to a question for Dr. Dexter that came about during your talk. And that is from somebody in the audience who's asking, what is well-selected patient based on Villalta, venous claudication, and so on, why 30% treated patients do not improve? David, if you would mind answering that.
Yeah, I'm happy to. So, I started out by talking about syndrome, right? And syndrome, and you heard me give a syndrome talk a couple of days ago in DC as well for Peter Pappas. I think that a lot of things look like a nail to a man with a hammer, right? So in the endovascular world, when a patient presents with pain, we look for a solution, and we could be vascular surgery, interventional radiology, interventional cardiology, but we may not be material experts in the organ system causing their pain. Pelvic pain in particular makes up something like 40% of all GYN visits. And the preponderance of seeing pelvic congestion syndrome anatomy in women that have had more than 2 pregnancies is a significant number of people, both on CT scan and venography. And just because you have these large periuterine, periovarian veins does not mean you have pelvic congestion syndrome. It's why we don't see OBGYNs as a field that believe in the disease. I think it's why we see that May Thurner was the predominant stent going in during the early trials. That case I showed was a Vici trial case. That was, I think, my first one back in like 2014. And now post-thrombotic syndrome and acute thrombosis are the reasons why many stents go in, at least in trial. So I think well-selected patients in the data that I was able to find on the internet is probably in air quotes. When you look at the data in the trials where non-thrombotic patients get stented, they match what I said. And we all see them in our clinics where you go, boy, was their leg swelling really venous etiology? Was their leg pain really venous etiology? And I think clearly now, post-operatively, the answer is no. But is there a better predictor of it? I think we have to work on it.
No, I completely agree. And, it's funny because I've had this question in the past about the nickel allergy issue. And if you talk to some other experts, I've had this discussion with Kush Desai, with Mark Meisner. They're like, yeah, just put this, stent in, or put the, the nickel-based product in, they'll be fine. But I'm kind of with Dr. Nagarsheth on this and the rest of you as to why is it that these patients get these crazy reactions. And I love the idea of gluing or taping the stent to the patient. Again, Dr. Nagarsheth, can you just comment one more time? Like, what do you think the difference is between the cutaneous hypersensitivity versus the systemic one?
So it depends on who you talk to. But when I talk to our immunologists here, they say that these patients all start with cutaneous, and most of the time they just sort of ignore it, or they use hydrocortisone and it improves, something like that. They think it's like a rash. So they think that that's the first step, is that they all get a cutaneous reaction, and that's kind of ignored, and then they have further exposures leading to a more systemic manifestation.
Do we know, can I jump in? Do we know if someone does, let's say you do that test and you put it on the skin and they have no reaction, is it like 100% that they won't have a systemic reaction?
No, because I think a lot of this stuff has to do with repeated exposures, right? And so that's why there was that thing I wrote about the number of piercings, right? The more piercings people have, the more likely they are to develop these kind of allergies. So if you put in someone who's prone to developing a nickel allergy and you put an implant in them, now they're continually exposed to it. So I think that they are at much higher risk. That being said, I mean, these stents, they will get kind of entomolized and kind of incorporated into the blood, into the vessel wall, as opposed to constantly being in contact with the bloodstream. But I think that's something we have to be cognizant of. And I agree with Dr. Davies. We have to ask these patients about their allergy history, much more involved than we do right now. I mean, asking about an acrylic reaction or anything like that is great for venous seal. And I ask all these patients about heavy metal allergy, and I ask them all about if they have issues with like cheap jewelry, right? That's the easiest thing to ask them. Do you have any reaction to cheap jewelry? And a good number of these patients will say yes, and those are patients that I send for further testing.
It's so funny that
sorry. The other thing that I was thinking as I was listening to your talks, maybe not so much with the stents, but the coils, do you think that the reaction is more with like heavier number or like bigger stents or like a larger amount per se of the actual material inside of the patient?
Yeah, so I think there's such a paucity of actual good data on this out there that's hard to say, right? Because we know what stents have what component of nickel in them. So it stands to reason that some of these stents are going to be more prone to developing these allergies than others.
Right.
And I can tell you, the people that I've seen that have developed nickel allergy after stent implantation or something like that, like a reaction, it's always been with a venous design stent. I don't remember seeing more than one or two people that had developed an allergy after a wall stent placement. And so maybe it has something to do with the nickel content in these materials. So that's why I put in the chat, maybe for younger people, we need to be using the platinum-based coils instead of nickel-based coils.
Have you ever seen an arterial stent show up with a nickel allergy?
That's a great question. No, I haven't, but I have seen a start close cause a cutaneous nickel reaction, which was after an arterial procedure. So I don't have, but I also think that it's something about this patient population, right? This patient population with compressions, this younger population that has hypermobility, that has POTS, that has mast cell activation syndrome. Like these are the things that I think these are the phenotypes that seem to predict or not predict, but push us in the direction that maybe these are the patients that we have to worry about. I'm collaborating with Dr. Sharma down at MUSC. He's the chief of GI there. And he's doing a lot of work on EDS, on hypermobility, and has actually found that it's actually more of a defect in the complement pathway in C3b, as opposed to anything to do with collagen, that there's a systemic inflammatory reaction in these patients because of a defect in their inflammatory cascade. So I don't know. I think that has something to do with it. I think it's the population we're treating.
Dr. Davies, do you have a question?
It was just a comment to David. If he wants to have a look at the review that we did on nickel allergy, you do get it with arterial stents, but it doesn't seem to be quite as prominent or obvious. But I think I'm going to say something now that may be completely incorrect because I don't know the answer to this, is whether ladies are much more likely to develop a nickel allergy as opposed to men. I don't know whether that's true or not, but I would surmise that women tend to have more attempts at wearing cheap jewelry and become more sensitized. So I do wonder whether I wonder whether there is also a significant difference between the age of patients that we're putting them in, and whether as you get older, you're less likely to react to nickel. I don't know, but those are just some general thoughts.
I do have to say that I cannot wear cheap jewelry. I always thought it's because I'm genetically clearly a princess, but but the
princesses, same here.
It's true though. Like if I put in fake earrings or anything like that, within a few minutes I start to itch, and so I never really. I started to realize that. So now when I see these young women in my office, I'll be the first to say, I understand the allergy you have because I have it myself. So if I end up on your operating room tables, please don't put anything nickel in me. Keep it platinum. Anyway, thank you for all your comments. And again, KJ, I noticed that you put it in the chat with the patient that you and I, were involved with. I made sure that those were platinum and not. And one last comment really is that with the Gore stent coming out, everybody's like, oh, wow, that's covered with PTFE. But I actually called them and asked. There is some exposed nitinol in those. And David, I know you're one of the PIs as well. I mean, I don't know if you want to comment about that, but I don't think it's safe in these patients.
So I will tell you that it probably should be treated like every other venous stent that we have from a nickel standpoint. So whatever your personal bias is, and I heard you loud and clear that people have their personal biases. Thursday, I put a bunch of platinum-based coils for a splenic artery aneurysm into a young woman with a nickel allergy. And she has an iliac vein stent that I put in, knowing she had a nickel allergy. And she's done great. So, I mean, it is super complicated to figure this out. It's been a great talk today. Really, really nice job, guys.
Yeah, I can't thank you all enough. We're over time, and thankfully Zoom didn't shut us out because I could talk about this for the rest of the day. Lina, I'm going to give this over to you for concluding.
Can you guys see our flyer?
Yes.
Beautiful. So yeah, this has been an incredible first webinar. Thank you to all of you for being here. This has been absolutely amazing. I've enjoyed this so much. And just before we wrap up and let everyone go, I just want to invite you to our next Venous and Lymphatic University webinar, which is coming up on Saturday, February 21st, same time, same place, 9 in the morning Eastern time. And we are going to focus on advanced training in venous disease and specifically how trainees and early career physicians can continue developing expertise beyond the traditional training pathways that obviously focus mostly on arterial and other conditions. So we're going to have an incredible international panel, and we're just going to be sharing perspectives from different regions of the world. And we would love for you all to join us. Again, just if you're early in your career and want to learn how the experts do it, if you're an expert and want to join us and share some pearls, we would love to see you all here next February 21st.
Thank you so much. Again, thank you to the panelists. Lina, you're an awesome co-conspirator. So thank you. And also thank you to VLU Executive Board for everything. And I hope everybody has a wonderful day.
Thank you. Bye, everyone. Have a
Bye,
wonderful
everyone.
day.
Thank
Bye.
you. Thanks.